So thank you very much. Yeah, prostate cancer does exist. We just have not only stones, we also have prostate cancer. And we don't have a lot of guidelines regarding the conservative treatment for prostate cancer, just active surveillance in case of low risk, low volume disease, which is a little bit different now for the prostate cancer because we discovered the prostate cancer earlier, and there are probably other options. So I would like to submit you these clinical cases. A gentleman, 57 years old, no medical history, APC at 8.7, nice MRI with a nice lesion, PIRAT4 on the right side, and all the targeted biopsy are positive, EGYP2 with 40% of pattern 4. So the subject of the day is how to manage this prostate cancer. So we have two debaters today, Clément, who will give us some explanation about focal therapy, and Andrea Gaglioli, who will explain to you how we have to do a radical prostatectomy. Clément, please.
Hi, hello everyone. I'm one of the local here, so I work at UCL, professor of urology, and probably my biggest disclosure is that I am a focal therapist, and this is the only thing I do. So thanks, Eric, for putting up this case. To exactly reframe it, the situation is a visible prostate cancer, and I think one of the biggest messages we can have now is that visibility of prostate cancer is probably the biggest driver of the disease and indicate the risk of the disease. That case is concordant with the pathology from the biopsy, targeted biopsy from this lesion on the right apex, 3+4, 40% pattern 4, and what we can say insignificant lesion 6, which has the base. In this scenario, the patient has a life expectancy which is compatible with benefit from treatment for prostate cancer, because this is one of the biggest thing to understand. It is if we need to treat or not to treat, and I think this is the biggest question. Here on the left, that's the curve from the PROTECT trial, which showed then this randomized controlled trial of surgery versus radiotherapy versus monitoring, a very loose form of active surveillance. There was no difference in survival at 10 years, but there was clearly some difference you can see on this curve in terms of progression of the disease towards metastatic status. And it correlates quite well with what we can see when we do active surveillance based on imaging, that Gleason 7, 3+4, when it is visible at 5 years, 50% of those patients will progress to our treatment. I think this is a type of information you need to give to your patients. There is very important to give a proper informed consent, explain to them the trade-off between what they can have as long-term benefit from treatment and the side effect profile they can get. So in this case, we can discuss the choice of energy, and again, this is MRI-based. We developed a framework where you can plan your treatment based on imaging, looking at the different sequences, and there is an active loop between what you can see, the margin you're going to apply. This is, now we know it, is very important to put a margin around an MRI lesion. And if we look in this case, which is on the right apex here, still at good distance from the rectal wall, actually you can apply probably HIFU, cryotherapy, or IRE. This is one of the rare cases where you can apply any modality. But really the message here is apply the energy to destroy the tumor safely with a margin. What expect in terms of functional outcomes? We know now since 20 years, this is a trial which has been published by UCL 20 years ago now, and systematically and consistently across the different series, we found like 85% of men can maintain erection sufficient for intercourse with a very low rate of incontinence, less than 1%, and this is coming back very quickly. When you remove the catheter, the patient are dry. In terms of oncological outcome, some result from our series in UCL. In terms of success, some would define it as the absence of transition to radical treatment. Across time, you can see nearly at 10 years, it's 20% of men who need to switch to radical treatment. So you can say like 80% keep their prostate in place. If you look a bit more into details, a lot of patients need, like 20% need a retreatment because you can retreat again with focal therapy. Linked to the concept of focal therapy, very important, you have around 15% of men who will develop across 5 years, 5-6 years, an out-of-field lesion. We'll talk about treatment, but in focal therapy, the follow-up is really important because you want to detect the disease which is coming back, because as I just said, you can retreat using imaging. This is a follow-up we apply at UCL and UCLH. And there is it's image-based. You've got hemorrhoid year 1, 3, 5, 7, and 10 years. And clearly, this is the biggest driver. PSA is obviously very important. It's a predictor. We've shown it that the nadir is predict if the risk of recurrence, but you can see the recurrence. So this is very important to guide your biopsy and retreatment. Another thing which is kind of new since a few years now, focal therapy is not experimental anymore. In the guidelines, you can treat using focal therapy within a clinical trial or within a prospective registry. So Eric is leading the Jupiter registry, which is like a EAU-led initiative which will recruit 1,000 patients to get some very good data across different centers, and we'll see what happens in the whole Europe. To conclude, visibility of prostate cancer is the main risk driver. Focal therapy is an option for patients selected, informed, willing to trade off long-term uncertainty. They will have a low side effect profile with comparable long-term outcome to radical prostatectomy or radiotherapy. And the MRI is a driver for selection, the choice of energy, and the follow-up. And now the guidelines allow to perform focal therapy if you record your patients in a registry.
Thank you, Clément. So now Andrea Daglioli will explain to us why to choose the radical prostatectomy in that case. You can continue the presentation because the slides are, yeah.
So, good afternoon, everybody. First of all, it's an honor to be here. Let's say the other face of the coin. So, when we are speaking about minimal invasive surgery, we are just speaking about oncological radicality, but it's also about anatomical preservation. It's about functional recovery. And I think that there are two concepts that we have to keep in mind. So first of all, prostate cancer is a multifocal tumor. In case of, when we're performing MRI may not see, in case of multifocal disease, which is up to 60% of cases, maybe miss one or more significant focus in half of the patients. And be aware that in 30% of missed and multifocal foci, this lesion harbor Gleason 4 or more. And we know from this study that actually 1 out of 3 patients had worse disease than expected in febrile intermediate risk disease. And is it clinically significant or not? Well, if you have a look into this study, you will see that 15% of cases were upgraded to ISO 3 or more, 12% of cases were upstaged to PT3 or more and PN1 disease. And we all know, and it's kind of logical to think that upgrading increases the risk of cancer-specific mortality, and both upstaging and upgrading, well, increases it more and more. So this is one of the reasons why we advocate for minimal invasive surgery. But it's not only about the access, it's also about the outcomes. Now I think I'm citing Professor Taxer, but right now radical prostatectomy means a world of possibilities, not the same that we are doing in intermediate risk febrile disease that maybe in a CT3 disease. And for example, in this setting, ratio-sparing prostatectomy is shown to provide very good continence rates and very quick recovery after the surgery, with a median time to continence moving from 8 days to 2 days in this very specific population, with outcomes that were comparable in terms of biochemical recurrence-free survival in both arms. And if we have a look into other techniques, one that may be performed also in laparoscopy is the hood technique. So the idea to preserve the periurethral structures, particularly anterior structures such as the Tuser apron, the puboprostatic ligaments, and the arcus tendinous, which may permit to have very good continence results at 12 months with a low rate of positive surgical margins. In this study, I would say the result is 6%. It's quite optimistic, at least in my hands. But anyhow, the key message is that we can have good functional result, preserving and being radical at both times. And speaking about nerve preservation, there are new techniques that have been developed. One of them is the SAFE technique proposed by Ashtewari, meaning that you can expose the fascia through a saline-assisted exposure, and these are shown to help the surgeon to identify the plane that he wants to follow, either the interfascial or intrafascial plane, with very good potency at 12 months. And we have also to keep in mind that there are new techniques that are being proposed, such as the NeuroSafe, in order to guarantee the radicality and to decrease the risk of positive surgical margins using frozen section examination of neurovascular bundle during radical prostatectomy. This is one of the, I would say, most renowned technique in order to decrease the risk of positive margins, but there is also confocal microscopy, which is gaining momentum at this time. And be aware that right now we are entering in the phase of AI real-time surgery, so probably we will experience new algorithm in order to detect the neurovascular bundle, and what you can see is what you can preserve if it's needed. So my conclusion is that given the results that now radical prostatectomy in febrile intermediate risk disease may guarantee, we can conclude that it ensures a complete pathological staging, oncological radicality, and functional outcome are far from being the one that we were talking about in the last 20 years. And I thank you very much for your attention.